我是杨瑞成，我的声音这样可以吗？
可以非常清楚。
好，谢谢。
前辈听得到我的声音吗？
听得到，很清楚，很清楚。
谢谢，谢谢执行长。
Hi, good evening, everyone. Welcome to Taiwan Healthcare Quality Association. And today's conference is the topic is patient safety and quality. And our speaker is Dr. Anuradha Pichumani and Dr. Chen Shey-Ying. And next slide. Okay. Dr. Huang Weichun is chairman of International Cooperative Committee Taiwan Healthcare Quality Association and chief department of critical care medicine Kaohsiung Veterans General Hospital. Then president Taiwan Clinical Infection Society International Society for Quality in Healthcare is called experts. And he's been busy tonight, so I request him for today's introduction. And next. Today's activity is held by Taiwan Healthcare Quality Association. Next. And the Joint Committee of Taiwan. Next. And Asia Society for Quality and Healthcare. Next. And this is Chair Wang Chin, and he's President Asia Society for Quality in Healthcare and CEO Joint Committee Taiwan. And next. Okay. And this is Chair Dr. Zheng Xiaoyu is President Taiwan Healthcare Quality Association. And today Dr. Wang Bachin, can you speak something?
President of the association, Dr. Cheng, and also the chairman of today's occasion, and our guest speaker, Dr. Anu, my good friend. Welcome you. Okay.
Welcome.
Thank you. Thank you for giving me this opportunity to give some talk at the opening of this event. As everybody knows, that Taiwan Healthcare Quality Association is a leading professional association in healthcare quality in Taiwan. So we joined Commission Taiwan and ASQUA. We are very happy to have this chance to work with THQA to have this joint activity. So today, I think the program is very excellent because we will tackle the new issue of the WHO new patient safety and the healthcare quality goals. I think our guest speaker and our domestic speakers will share their experience with us. So I wish the best of the success of today's event. Thank you. 谢谢.
Thank you. And next, we want to introduce Dr. Zheng Xiaoyu.
Good evening, everyone expert in the healthcare quality association from the Taiwan, Indian, and other country of Asians, and the friend of the Asian Medical Quality Associations. Well, I am the president of the Taiwan Healthcare Quality Association, Zheng Xiaoyu. Today, I am very happy to report to you this time that we have joined the organized THQA, Taiwan Healthcare Quality Association, and JCT, Joint Commission of Taiwan, and the ASQUA, Asian Society for Quality in Healthcare, co-holding a forum on the healthcare quality and patient safety to share their experience and result together. Experts providing each the effective model to cross international exchanges. Everyone understands that the patient safety is the core element in the medical care. When we talk about the healthcare quality, we must focus on the patient safety care. Therefore, we invite several experts scholarship, including the Dr. Anuradha Pichumani from the India, and to share their experience through this forum experience. Today, I would like to thank distinguished guests. Say the Dr. Anuradha Pichumani from the Indians, and Dr. Wang Bachun, CEO of our Joint Commission of Taiwan. She is also the president of the ASQUA in the arranging this event. I look forward to everyone participating and witness this conference. A good beginnings is a new beginnings. We will work together to improve the healthcare quality of Taiwan and other Asian countries. Hope this is the start in the future. There will be more opportunities to invite outstanding healthcare quality achievements and of the Asian countries or the institute to share their successful patient safety and quality care outcome. I wish everyone good healthcare and good luck. Today's speech and the discussion will bring you to a full rich harvest rescue. Thank you all.
Okay, thank you. And next slide. Okay, let's begin today's webinar. And next, this is our today's schedule, and let's start with our moderator, Dr. Yang Chen, to introduce our today's speaker. And Dr. Yang Chen.
Thank you very much.
Okay, thank you.
Good evening, ladies and gentlemen. I am Yang Chen, a pediatrician from Kaohsiung Medical University, Taiwan. It's my great honor to moderate the special talk presented by Dr. Pichumani today. Before her presentation, I would like to introduce Dr. Pichumani in brief. As you all know, she is an excellent clinician, majored in infertility, laparoscopic surgery, and act as executive director in Sri Lanka Hospital. In addition to her clinical professional, he paid a lot of attention in improving quality of healthcare in India, as well as the whole world. She is now an elected member of the executive board of ASQUA and the chair of the education committee, ASQUA. Also, an ASQUA expert and tutor, NABH assessor, and also a chairperson of CAHO. I'm especially impressed by her achievement to nurture the Sri Lanka Hospital from a 2-bed nursing home into a 47-bed multi-specialty hospital, and earned the NABH accreditation under main standard. Certainly, he has been awarded by many international academic institutes. Today, she will give us the special lecture about the WHO Safe Childbirth Checklist, SCC, and share us her experience of its implementation in India. Let's welcome Dr. Pichumani. Dr. Pichumani, please.
Thank you so much for the kind introduction. And I would like to congratulate the Taiwan Healthcare Quality Association, the Joint Commission of Taiwan, and the Asian Society for Quality for joining hands to conduct this webinar, especially Dr. Pachung Wang. And this has enabled an opportunity for knowledge sharing. Thank you all.
So, hello everybody. Thank you for inviting me here today. I am Dr. Anuradha Pichumani, an OBGYN consultant, and I practice in the southern part of India. So at the outset, I would like to thank and congratulate the Taiwan Healthcare Quality Association and the Joint Commission of Taiwan, and also the Asian Society for Quality in Healthcare, the ASQUA, for joining hands to conduct this webinar. And this has enabled an opportunity for knowledge sharing. So congratulations once again to all the organizers for putting up this event together. And I'm going to share my thoughts on the quality improvement in obstetrics care, specifically with a special focus on the implementation of the WHO Safe Childbirth Checklist. So as you all know, quality is everyone's responsibility. Quality is a way of thinking about our work, how we are going to approach it, how we are going to make it more better for our patients, for our healthcare workers, be it doctors or our nurses. And as healthcare providers, we might feel it is an idealistic goal. And as clinicians, more so because we are already stamped up with our daily activities and our duties and our commitments. So it's no wonder that many of the clinicians always tend to see quality improvement as an added burden. So that's why quality improvement frequently requires a fundamental shift. So this fundamental shift should be in our cultural approach, and it has to come from the top leadership down to our clinicians and also to our healthcare workers. So we now need to see what is high quality maternity care. So by high quality maternity care, this is a fundamental value, a principle and a goal which we have to offer to all our patients. So a high quality maternal care should always be women-centered. So the caregivers should respect the women's values, her cultural preferences, her choices, and the childbearing women should be treated with kindness, respect, and dignity, and also for the cultural sensitivity. This is very important for each and every woman who enters a hospital. A high quality maternal care should be safe and give the best outcomes for the mother and her child with the least risk of harm. And to be made more safer, this requires a high degree of coordination, a high degree of teamwork, and also a commitment to safety. Again, it has to be effective. The treatment what we give should be based on the available best research possible, and caregivers should avoid practices which are ineffective or harmful, and we need to incorporate the best practices which are shown to improve the healthcare outcomes. Again, the care which we give should be timely. A mother should not be made to wait unnecessarily and for long periods of time. The time of progress of labor and birth should be based on the healthiest options which are available for the mother and her infant. And it should not be for our own convenience or other pressures. It again has to be very efficient. So it has to give the best possible outcomes and with the most appropriate use of your resources or the technology. So the efficient system will not waste on any resource and will not expose the woman or the infant for unnecessary treatments or interventions. So the care what we give should be efficient, and a high quality maternal system should be equitable. So every woman has to have the access to the same level of high quality and high value care. And also it has to address the disparities related to the class, race, or the ethnicity. And we need to ensure that optimal maternal outcomes and experiences are available for every woman, her infant, and for the family. So this is what we mean by equitable. So when we see what WHO is giving us as statistics, still there are nearly 5,400 stillbirths which occur every day, and 810 women lose their lives. And again, 6,700 newborns lose their lives. These lives are being lost during childbirth, and most of these lives can be saved through provision of safe care. This is a study which was given out in Lancet, and this is the no-do gap. This is a huge fundamental problem in all our healthcare systems. When we see this paper, there are about 3.6 million deaths which have occurred due to insufficient access to care. These are women who have not entered the hospital, whereas again, there are more than 5 million deaths which occur due to poor quality care. These are women who are delivering inside a hospital, but still we have more people dying because of poor quality care. So poor quality care is a bigger killer than insufficient access to care. So this we need to address by strengthening our healthcare systems. And this is a latest publication which has come out in the NHS. So this is Mind the Implementation Gap. And this report tells us about the continuation of avoidable harm which is happening inside the hospital. And we need to spend more amount of our resources in treating this harm which has occurred. So instead of that, we need to strengthen our health system and provide excellent quality care and prevent all the avoidable health harms. And again, when we see this is from US. Medical error is now considered the third leading cause of death, next only to heart disease and cancer, which occurs inside the hospital. So it is very important we provide safe care to our women and child. And this is what was been given by the World Health Organization. And patient safety is a global concern across countries now. And it is a fundamental principle of healthcare, and delivering safer care in a complex, pressurized environment, like be it in a labor room or during delivery, is one of the greatest challenges which is being faced by every healthcare organization. We need to ensure safety for each and every mother and a child who enters a hospital, and safety should be made the highest priority. And for this, we have got this type of safety tools. And this is one of the safety tools, which is called the WHO Safe Childbirth Checklist, which we are going to see now. And this tool addresses most of the major causes of the maternal and neonatal death. And this tool helps you to synthesize the various WHO's evidence of care practices, the various recommendations for safe childbirth. And this has been made into a simple practical tool, which helps the various healthcare workers working across the globe. And this helps the healthcare workers to adhere to the safe practices, which is needed for every child birth. And this is a tool, which is a 4-page one, and it targets the major causes of maternal deaths, the intrapartum related stillbirths, and the neonatal deaths. And it can be used by obstetric departments and public-private healthcare facilities. And each healthcare facility has to be taught to adopt, adapt, and practice this WHO Safe Childbirth Checklist. It has been given by the WHO. And when we see how these checklists have come into use, so these checklists was first used in the World War II. So in the World War, we saw the B-17 bomber flights which were being used. And when the first flight took off, it crashed. So what the people in the US Army Corps did was quite interesting. They did not increase the training, because the person who piloted the first aircraft of B-17 was a star performer. He was a star pilot, but the aircraft crashed. So they did not increase the training, and they did not change the craft. What they did was introduce a simple checklist. This was now the legendary safety checklist, which every pilot and crew is using it in the cockpit. And as they started using it, they were able to see the risk of fatal errors, which reduced dramatically. And this has become mandatory in the aviation industry. So similar to piloting a massive warplane, surgery too has its own risk. Surgery and aviation have many similarities. Both disciplines have made extraordinary become ordinary by involving huge team of specialists, and it involves huge expensive amount also, equipments, and we are performing unimaginable tasks in life-threatening situation. So we need to make our process more stronger, and for this, we can use this simple checklist in our theaters also, in our labor rooms also. And as surgeons and educators, we are obligated to teach our juniors not only how to operate, but also we need to help them to develop a separate mindset to follow the system and processes which will make our patients more safe inside our hospitals. So when we go through these clinical guidelines, which have been given out by the American College of Obstetrics and Gynecology, this advisory came out in 2019. It talks about the clinical guidelines, standardization of practice, to improve the outcomes. So it talks about the protocols and checklists. We need to follow this to standardize the practice across hospitals. And again, it talks about checklists where we have to create checklists by engaging our own team of obstetricians and gynecologists so that they are engaged in developing these guidelines, which in turn help to make them adhere to these guidelines and protocols better. Because only if you involve the stakeholders, it will be more easier. Again, the standardized care helps you to improve the quality of care inside the hospital. And again, it reduces the variation within the hospital, within departments, and also improves the safety of care. So standardization based on protocols and checklists is the mainstream, and all of us have to follow it. And the WHO Safe Childbirth Checklist helps you to formulate this. It has 28 essential birth practices which have to be done across 4 pass points. The first pass point is at the point of admission. The second pass point is just prior to delivery. The third pass point is within 1 hour of birth. And the fourth is just before discharging the patient. So these are the 4 touch points where this essential birth practices have to be followed. And this safe childbirth checklist is now being used across the world. In many of these countries, this is a list of countries which are using the safe childbirth checklist. And we have a WHO Safe Childbirth Collaborative, which included implementation teams from across 39 sites from 19 countries, which explored the barriers and challenges in implementing the safe childbirth checklist. And this is the overview of the countries implementing this checklist. We have from Africa, 13 countries, from America, 8 countries, from Asia, there are around 6 countries, from Eastern Mediterranean, it's 5 countries which are practicing the safe childbirth checklist, and from Europe, there are 3 countries which are using the safe childbirth checklist. We see from the Asian countries, some of the member countries of ASQUA is using it. So this is a time where we can utilize this opportunity to implement this safe childbirth checklist in other ASQUA member countries as well. Again, this was a paper which came out in 2021, which talks about the adaptation and implementation of the WHO safe childbirth checklist across the world. So we have various type of implementers. These are the various type of hospitals which are implementing this checklist. We have non-profit organization, academic institutions, teaching institutions, private sector or public sector, and it can be a primary healthcare facility or a secondary or a tertiary facility. So there are various types of implementers who are using this safe childbirth checklist. And this checklist, when we talk about this checklist, this is one of the important study which was done by the Ariadne Labs for this implementation of the safe childbirth checklist. Ariadne Lab is a joint center for the health system innovation at Brigham Health and Women's Hospital and the Harvard T.H. Chan School of Public Health. So Ariadne Labs was a critical partner in the Better Birth study. And this study evaluated the impact of the WHO Safe Childbirth Checklist across 120 primary healthcare facilities in Uttar Pradesh state in India from the year 2014 to 2017. And what they did was they tested around 1.6 lakh women and newborn parents. This is a huge study, which was done for nearly 5 years, and 5,000 plus deliveries were observed and various health outcomes were measured. And though we were able to show there were significant improvements in the adherence to the essential birth practices, what was found was this alone was not enough to reduce the overall maternal and perinatal morbidity and mortality. So this was brought out in the Better Birth study, which emphasized the importance of the ecosystem, where this ecosystem of the facility-based childbirth involves, it should involve the women and the community, where the patient is delivering, the birth attendants who take care of the mother, the frontline facility, the organization, be it a primary or a secondary or a tertiary healthcare, and the health system, which as a whole has to function to put out various protocols and checklists. So this ecosystem has to take care of all the gaps in between. Only then there will be a reduction in maternal morbidity and mortality. But for all this, the Safe Childbirth Checklist is a very important tool to implement. So we will now see the various pass points across which this tool has to be used. The pass point 1 is at the point of admission. This is the first contact of the mother with the organization. We can pass and review whether the mother has been assessed properly, brief the mother and her companion to prepare her for labor and delivery. You need to educate her for the danger signs when she should call for help. Moving on to the pass point 2, this happens just before delivery, just before the mother starts pushing or just before the cesarean. So it is very important to take care of any complications which can occur. You have to be prepared to face any crisis or any situations which can occur. So you need to get your equipments and everything ready. And moving on to pass point 3, this happens soon after birth. The first 1 hour immediately after delivery is very important for the mother and for the child. The monitoring has to happen. You need to see whether the mother is recovering properly after the delivery and baby is being the transition of the baby from the womb of the mother and into the world. This has to happen properly. So any complications which can occur, we need to be prepared to face the complication, to treat the mother, and we need to pause and review whether the mother and baby are fine, to ensure that practices like breastfeeding and skin-to-skin contact is being done. And the next pass point is at pass point 4. This happens just before discharge. You're going to ensure that the mother and child are fit enough for discharge. The follow-up is done, and you need to give them the date when they have to come back. The family planning counseling has to be done. All these things have to be taken care of during the pass point 4. So when we talk about the safe childbirth checklist, this checklist allows us to adapt the structure or the content. You can change the structure, but you need to include all the 28 checklist points which have been included in the checklist, but you can change the form. It can be translated into your local language, can be combined to fit into one single page, or you can change the content based on your local or national guidelines so that the adherence is more better. And you can include the respectful maternal care practices. You can even include the various management items, be it checking whether the blood is ready, at least 1 unit is ready, whether checking the transport for the mother or baby is arranged. All these things can be adapted. So in the year 2020, the Safe Childbirth Checklist was checked. We wanted to survey and interview people. So around 29 surveys were done, 12 interviews were completed with the implementers, and RENA did this interviews, and they selected 2 countries, 2 hospitals, 1 hospital from India and 1 hospital from Rwanda to be the implementing partner for the RENA labs. And we are very happy that our hospital was chosen from India to identify the promising practices for safe childbirth checklist implementation, to introduce our hospital. The hospital is called Sriranga Hospital. It is in Chengalpattu district in Tamil Nadu in India. And we implemented this quality improvement project in a hospital. Ours is a 47-bedded small multi-specialty private hospital catering to semi-rural population from various villages, and it is a semi-urban town. And our focus is on obstetrics and other specialties also. And we have a strong focus on various quality practices. We have got our national accreditation on healthcare standards, the NABL, the NABH, the ISO standards. Manyata has been done in our hospital. We have done the WASH, Kayakalp, all the CQPs. Our hospital is a Center for Quality Control. So all these things are related to various quality projects. And this has been done in the hospital. And we have been following the WHO surgical safety checklist since the year 2010 for the last more than 10-12 years. And we started implementing the safe childbirth checklist in the year 2019. So this checklist implementation goes through various phases: the engagement phase, the launch phase. Then the third phase is support phase, which includes the coaching. Then you need to measure the data. And with the data feedback, you have to improve on the coaching. And based on the results, you take care of the support system in the hospital to strengthen the individual and the system standards, so that this leads to better maternal and neonatal outcomes. So moving on, we started with the project design phase. The project was integrated into a quality improvement initiative, and we got the feedback from all our stakeholders. We had included 40 new elements in various versions of these checkpoints. And then when we started the implementation, COVID-19 pandemic broke out. But in spite of it, we were able to move on with the quality improvement initiative. We started out with the engagement phase. And our team consisted of 3 obstetricians, anesthetists, pediatricians, nurses, nurse aides, and technicians. We conducted a gap assessment in the hospital. And based on the gap assessment, we were able to give the training to our employees, to the staff, the frontline workers. And then the data was collected and we started the analysis of the data. So during the launch phase, we launched it in a monthly committee meeting in the hospital. And for the launch phase, we involved the top leadership of the hospital, because involving the top leadership is very important to sustain the whole project. And we discussed the challenges in the implementation. The feedback was got from the stakeholders. And then this was also addressed and included in the checkpoints. And this helped to improve the coordination among all the staff. In the support phase, we had a continuous coaching and motivation happening through various groups, through various forums. We included live demonstrations so that the training was implemented, and we identified a nurse champion among the team so that the adherences of the practices was taken care of. And we improved the timely posting of this each and every checklist on a separate WhatsApp group. And based on that, we started an evaluation phase. So the first cycle, the first PDSA cycle, the Plan, Do, Check, Act, was done from March to July 2020. And we took it up in 2 QI cycles. In the first cycle, the aim was to ensure the completion of all the elements of the checklist across the 4 pass points. And what we saw was an improvement from 48 to 77% in the first QI cycle. And when we started the second PDSA cycle from August to December 2020, the improvement of the completion of the 4 pass points increased to 90%. And the second aim was now to check whether it was being timely completed. Each and every pass point was checked. When we saw the completion increased to 77 to 94, and the timeliness of completion started improving to 70%. This is a simple dashboard for the monthly reporting of each of the 4 forms. And based on this quality improvement project, we saw that it started increasing from 80 to 100%. The compliance after 2 years now. We did this project in December 2020. And even after 2 years, the compliance is nearly at 100%. So the timeliness of completion has also increased from 70 to 90% now. And I can take you through some of the challenges what we faced when we implemented this quality improvement project in our small hospital. First, the WHO Safe Childbirth Checklist was thought to be an additional paperwork by the staff. So we then had a meeting with our staff and told them about the importance of this. And then it was included in the medical record, and then the implementation started. Again, we had a challenge in implementation and documenting the partograph, because and so we gave them the training, and this training was imparted by our obstetricians so that they understood how to document a partograph. And those challenges faced because of continuing with the sticky practices like hand washing, breastfeeding, and skin-to-skin contact. So we were able to go through this challenge by implementing, by appointing a nurse champion who was able to do the continual motivation and coaching for all staff members. Then the monitoring and the completion and the timeliness was checked by the WhatsApp group. It was a real-time monitoring. And based on this, we were able to find that this is a low-cost implementation, and this has improved and strengthened the whole process in our hospital. So the labor room is more safer for our patients. It has boosted the confidence in delivering a safe obstetric care to our mother and the child. And this has been, there has been easy handovers. This is an easy communication tool. It is being now used as a handover tool among the staff nurses to check if there is anything to be done by the next nurse on the next shift. And hence errors due to miscommunication has definitely reduced. So based on this, we came out with a paper in 2021. The paper was on the Journal of Global Health Reports. The paper was on the promising practices for adapting and implementing the WHO Safe Childbirth Checklist. And we had included the case studies from India and Rwanda. And I thank the RET teams for this. And the key messages in implementing WHO Safe Childbirth Checklists, you need to adapt to the local context. So only when you start adapting it, you will be able to do the implementation, and the adherence by the stakeholder will be good. You need to have a leadership buy-in. You need to involve the top management in this whole quality improvement project, and you might need to do a field testing, a pilot study before you take it on. And again, you need to have an optimal enabling environment, and you need to take care of the resource constraint. Only when you have ample resources, you'll be able to move on with this quality improvement project. So based on this, based on our hospital quality improvement, we then did a pilot study. I did a pilot study with an organization called CAHO. CAHO is a consortium of accredited healthcare organization in India. CAHO is committed to safer patient care, and it works across every state in India. And also it has various international linkages. So with CAHO, we took the help of our Gynecological Society of Southern India, the OXY, the Obstetrical and Gynecological Society of Southern India. So with these two organizations, we were able to involve in the pilot study around 12 hospitals. This is the team of the obstetricians, the team members, which included the quality team, the nurses, the frontline workers, and these are the hospitals. And we had various facilities participating, be it primary hospitals, secondary and tertiary centers. We had a variety of the number of deliveries happening, the variety of certifications the hospital had undergone. So we have checked it in the last 6 months, and the project is getting completed by this month. And we were able to show that the compliance of the safe childbirth checklist has increased to more than 90% across the various hospitals. And it has been a great improvement in quality in every hospital now. So we now see that a simple checklist can save lives. The effectiveness of every checklist is based on the quality of the checklist. And again, it is very important. It is very thorough. It includes all the checkpoints, and the checklist has to be accepted by the frontline workers. Then only the compliance will improve. And again, when the checklist is being introduced, the culture of safety in the organization is very important. That only will take you through to sustain the whole checklist. And when we see the benefits of checklists in healthcare, it helps you to promote the various processes happening inside the organization. It standardizes the process. It helps you to reduce the error, improve the patient safety, and also among your staff members, it increases the sense of confidence, improves the teamwork, so that it helps you to make your hospital more safe. And again, when we talk about the World Patient Safety Goals, which was given by WHO for the year 2021 to 2022, the theme was on safe maternal and newborn care. And the various goals were on to reduce the practices of unnecessary harm, to improve and strengthen the capacity for inside our organization to promote respectful maternal care, improve safe medication use, and analyze the various safety incidents during childbirth. And for all this, to improve the patient safety, the WHO Safe Childbirth Checklist is an important tool. And when we talk about the discussion on various quality standards and initiatives, all of us have one goal in common, that is to have an optimal maternal health outcome, be it for the mother or for the child. And this optimal maternal health outcome can be best achieved only in an atmosphere of effective communication, with a shared decision-making, with a great teamwork, which will help you to have various good quality improvement initiatives. So I welcome you all to take up this WHO Safe Childbirth Checklist, which is a priceless tool to improve the quality of services in the field of maternal and child health. Thank you. Thank you for your patient listening.
Thank you very much, Dr. Pichumani. Can we have some question or comment? Okay, maybe the detailed discussion will be performed after the next section. So let me thanks Dr. Pichumani again. Now the section is closed.
Okay. Thank you for Dr. Pichumani, a very excellent and impressive speech about quality improvement in obstetrics. My name is Shey-Ying Chen from Taiwan, Kaohsiung, and I'm a director of cardiology in Ruan General Hospital. It's my honor to introduce my next speaker, Dr. Shey-Ying Chen. And Dr. Chen is a famous professor in Taiwan and he is the director of National Taiwan University Hospital Center for Quality Management. He is also an attending physician of emergency department, and Dr. Chen is a pioneer of healthcare quality in Taiwan. And he also has excellent experience of patient safety, design thinking, internal medicine, and infectious medicine. Today, he will give us a speech. The topic is patient safety and quality improvement to mitigate the impact from COVID-19 pandemics. Let's welcome Dr. Shey-Ying Chen. Dr. Chen, please.
Excuse me, cannot hear you. Cannot hear you.
Yes, we can.
Is that okay?
Okay.
Okay, now. Okay, now.
Okay. Thank you for Dr. Lin's introduction. And today is my great honor to have this talk about the patient safety and the quality improvement to mitigate the impact from COVID-19 pandemics on non-COVID-19 patients. Actually, this is a great topic. So today I will mainly focus on cardiovascular events. As Professor Lin's introduction and the emergent physicians of National Taiwan University, this is why I'm especially interested about this topic. But I have no conflict of interest in this topic. This is my today's outline. So far, we have more than 570 million of confirmed cases and more than 6 million deaths globally by yesterday. It is not difficult to figure out the effects of the COVID-19 pandemic on healthcare systems and the population behavior. So, for example, usually the population will delay seeking medical attention by patients themselves because of the threat of getting COVID-19 infection. The stay home, stay safe policy, and sometimes they were in quarantine and the social isolation, and sometimes the loss of OPD follow-ups and the decreased medical compliance. For hospital, the COVID-19 patient surge overwhelms and paralyzed the medical institutions. So many non-emergent medical services such as diagnosis, surgery, or chemotherapy was mostly postponed or delayed, or canceled, or even canceled. And sometimes we have delayed timely resuscitation and the intervention in hospital ED and in wards, because sometimes the need of the additional process required for infection control, such as this virus screening or wearing of the PPE. And mostly in a large-scale surge, sometimes the hospital will shortage of the manpower, equipment, and the medical supplies. But we still interested to wonder how bad the COVID-19 pandemic affect patients, about patient care and the quality and the outcomes in non-COVID-19 patients, especially for acute myocardial infarction patients and the ALCA patient. About the acute myocardial infarction, the effect of COVID-19 pandemic acute myocardial infarction incidence mortality during COVID-19 has published in many papers. During large-scale community outbreaks, there was found a decline in the acute myocardial infarction admissions, hospital admissions, and the acute fibrillation admissions. Even though the admission rate, the frequency of the admission decreased, but there was the corresponding rise in acute myocardial infarction mortality in non-infected hospitalized patients. So the STEMI mortality increased for about the 3 times of the before and after pandemic in one report. There were also observed the STEMI intervention complication rates increased by over 80% in another report. The overall AMI deaths increased by 75%. How about the effect of the behavioral of the seeking medical care? It was observed the strict government instruction to stay at home and the fear of the contagion of getting infected with COVID-19, and the doubts about to seek medical attention because the citizen or the patient usually thought the hospital is already overwhelmed with COVID-19 patients. So it's a risk of and it's possible cannot get adequate treatment in the hospital. And mostly the social isolation from family members might have contributed to the low or delayed detection of the myocardial infarction at the time of the symptom onset. How about the effect of the hospital management on acute myocardial infarction? It was found usually we have the prolonged triage with time. Sometimes it's the COVID-19 and the myocardial infarction patient symptoms is pretty similar. So there is this possibility of the misdiagnosis. And there was a reduction or delays in primary catheterization intervention procedures, and a significant delay in time to revascularization for STEMI patients. And sometimes there is even a more resource limitation, as the catheter was mostly converted to the COVID-19 intensive care unit when a large-scale outbreak. But there was other studies to observe the quality of care about the AMI patients after hospitalization. One study from the United Kingdom that compared before and after the outbreak of the large-scale pandemic outbreak. They include many patients in more than 186 hospitals. They found that there was an improvement in attainment for 10 of the 16 major quality indicators. So it's pretty surprised that the quality of care improved after the community outbreak of the pandemic. But we still observed a tiny decrease in the ternary reperfusion with statistical significance in this study. Overall, the competition quality indicators improved from 44% to 45%. So the quality of care actually improved after pandemic. How about the auto hospital cardiac arrest resuscitation? It was observed an increased OCA instance during COVID-19 pandemic. In Italy, OCA instance correlated with the daily new cases of COVID-19 patients during the COVID-19 pandemic. In one study from New York, OCA instance increased about 3 times after COVID-19 pandemic compared to the pre-pandemic period. Overall meta-analysis showed the instance of OCA during pandemic was 1.2 times of the instance before pandemic. In our hospital, in our hospital emergency department, we have a very well organized resuscitation team for OCA patients. Each staff have well designated jobs when doing resuscitation, included in the airway team, cardiac team, leadership, and 2 supports or even more supporting staffs. However, after the community outbreak of the pandemic of COVID-19, the resuscitation device procedures and the space was limited in a negative pressure run. So in this limited space, only 3 staff, 1 doctor and 2 nurses was allowed to resuscitate patient in this negative pressure run, and 1 another supporting nurse in the anteroom. So the the drug or even the resuscitation devices is much more difficult to transfer from anteroom to the resuscitation area. So we found a significant decrease in the rate of the rate of the RSC rate after 2021 and the 2022 community outbreak in Taiwan. We also found that we have to pay more money to resuscitate OCA patients. because we have mostly we have to pay more money for the PPE or other devices or supplies. How about the COVID-19 pandemic impacts on other non-COVID-19 diseases or even preventive vaccination? For cancer patients, it was observed there was a reduction in the diagnostics procedure volume. So it's consequently, we found a delay in early diagnosis and a delay in timely treatment, including surgery, chemotherapy, or radiotherapy, and so on. How about sepsis and the critical ill patients? There was increased accrued 30-day or in-hospital mortality, an increase in severity of disease at the time of admission. Also, there was increased in hospital length of the stay in either ER, ICU, or floor. However, if we adjust the potential confounding factors for mortality, the 30-day mortality was not significantly different between the pre and the during pandemic groups. So hence, the possibility of the delay in presentation to hospital, but no reduction of quality of care. So we also observe the market drop in vaccinations and the primary prevention services. This is a brief review of other diseases for our audience. So how can we improve the patient safety and quality during the surge? Well, actually, this is difficult to say, but we for hospital and the healthcare workers, the hospital should provide staff safety for adequate PPE or vaccination if the vaccine is available. We need to provide psychological support, and we have to provide just-in-time training and even simulation before our staff get to take care of these patients. And we have to promote a culture of safety, resilience, and learning. For patient care, we have to provide updates, information, infection control guidelines, and work with the human factors and the economics specialists. We need to adjust existing the protocols to be more applicable and as the situation of outbreak evolves. So if it's possible, especially in emergency department, we might design a preserved space, capacity, and fast track for non-COVID-19 patients with unstable vital signs or the high probability of myocardial infarction or even shock. We have to coordinate risk and the potential failure mode identification, analysis, and then brainstorming, figure out if a possibility of the risk reduction solutions to cope with the difficult conditions. And we have to develop clinical decision support systems to facilitate patient care. And it's important to prevent pandemic-associated pressure sore because most of the time, these patients was isolated in a negative pressure room or a single room. So the care quality of a care member is significantly decreased. So it is important to prevent the pandemic-associated pressure injury. For citizens, it is important to identify and disseminate patient self-management tools for them to easily to care their for themselves to care their own chronic illness, such as diabetes or chronic wounds. And the ideal condition is we have the physical distancing, but not social distance. It's a little bit different because of visitation policy to maximize the patient support in a stay home and a stay safe policy. We might we might have a better use of the telemedicine, tele-rehabilitation, or tele-consultation. So the chronic care of their disease will not be discontinuous or can keep continuous. And sometimes the wearable devices for vulnerable populations or infected patients when they was quarantined or isolated at home is helpful to detect early deterioration of the infection or the disease. So let's make a brief conclusions. I think the COVID-19 pandemic impacts significantly on many medical conditions, including myocardial infarction, stroke, sepsis, or other critical illness, cancer, or also public health interventions, especially during large-scale community outbreaks. However, the evidence about the effect on quality of care after hospitalization remains controversial. Nonetheless, the healthcare systems experience a massive and rapid procedural process of the organization change at the time of pandemic crisis, and the quality improvement and the patient safety. People can and should contribute their expertise to their know-how and the know-why to help improving care quality and the safety when cope with the COVID-19 pandemic. Thank you. This is my today's talk.
Okay, thanks. Okay, thanks, Dr. Chen. Have the excellent talk about the COVID-19 impact on the cardiovascular disease. And we move to the session is the panel discussion. We are also invited the speaker, Dr. Chen and Dr. Pichumani. We can discuss together. So, are there any questions from our audience, online audience? Do you have? Are there any questions from our online audience? Okay, you know, I have one question for Pichumani. It's that, how about we think that the safety childbirth checklist is a good and simple checklist for our clinical practice, and you have a good team to implement the guideline. We know that always in our hospital, in our institute, maybe have the gap or barrier in the implementation guideline. Do you have any experience and how do you overcome the barrier? And do you have any experience to share with us when you implement the safety childbirth guideline?
Yes, Professor. Thank you for that question. So it is indeed difficult when you start out with any quality improvement project. Only with a very good team, you will be able to achieve any improvement in any change in the safety and quality in the hospital. So the first thing is you have to involve the top leadership. So that is very important so that you will be able to move across the organization, get the resources, and you'll be able to show improvement. So as we started out the implementation, we involved the top leadership of our organization. And again, when you start with any quality implementation, it will be good you involve all the stakeholders. So we called for a meeting with our obstetricians, pediatricians, anesthetists, and also the nurses, the technicians who are involved in the labor room. And so we asked for their opinion, their feedback, and based on it, we were able to move on. So this is the way we are able to do the quality improvement. And again, it's better you involve these stakeholders when you are going to do any checklist. So involve their stakeholders like your frontline workers, your obstetricians also. And again, when we started out, as I was explaining it to you, we had 3 or 4 barriers. One was the documentation of the partograph. So for that, we asked the obstetricians to start the training to our nurses so that the partograph is being implemented. And again, the way we went about is we were able to form a WhatsApp group, which helped us to see the real-time monitoring. So whenever they've finished any checklist, they used to take a photograph and post it on. So in that way, the evaluation was easier. The monitoring was also easier. And also to continue with the, to improve on the barriers, we had a champion, a nurse champion among their own group. And this person continuously motivated the employees. So motivation is very important when you go on with any quality improvement program. Thank you.
Okay, thank you, Dr. Pichumani. You talk about the team and the motivation. I think is very important for the implementation of the guideline into the real life practice. So may I have a question to the Dr. Chen? Yeah, we know that the COVID-19 in Taiwan, we have a lot of rule before admit the patient with the non-STEMI and who need the emergent D2B procedure. So do you think the rapid test of COVID-19 before admission to or before the emergent D2B process, is it delay the process or not? And does it impact the patient outcome? Okay, please turn on your phone.
Okay, thanks for these important questions. Because as it was required, the ask for do the COVID-19 screening before the patient was admitted to the hospital. I think this is still important and neat, but the screen of the COVID-19 should not delay the treatment for acute stroke or acute myocardial infarction. So the test should performed concomitantly with the intervention, the current intervention, brain intervention. And usually before the complete of the treatment and preparing for transfer to the ward or in the intensive care unit, the test should be available. So it is still time window to get the COVID-19 test result, but without the need to delay the treatment for the life-saving or brain-saving procedures. So I think this is important. So we do the test before hospitalization, but not necessary before the intervention. So we can save the patient and prevent the outbreak in the hospital ward or intensive care unit. Thank you.
Okay, thanks, Dr. Chen. I think we also have the panel discussion from the Dr. Zhang Wanchuan. So do you have any add-on the comment about these two questions about do you have add-on more comment about the two questions? So please, can you give some comment?
Oh, I have no comment for these two problems. And I got one question on our chat room, and again, Ms. Rumani have answered my questions. Thank you.
I have a question for Dr. Numani. Your presentation is very good. I want your hospital. How can you share decision making in your children checklist?
Can you repeat the question, please? How can you?
I want in your hospital, how can you use your decision making in the children's checklist?
Okay, you want me to talk about the decision making in using the checklist?
Yes.
Okay, so we took the decision based on the quality improvement practices which we have been following all these years. So the last 20 years we have been into some form of quality improvement in the organization, and that's how we came across this WHO Safe Childbirth Checklist tool. And then we took a decision of implementing it in our labor room so that it will improve on the quality improvement practices. So we involved the whole team, which included the top management, the nurses, the doctors, the obstetricians, and we had a meeting, and then we did the training for this checklist, and then we went ahead with the implementation. Does it answer your question?
Okay, thank you.
Thank you. Thank you so much.
Okay, so maybe the time is limited, and we have to close the panel discussion and move to the final to the Dr. and Professor Huang Wei-Chun.
Yeah, thanks, Professor Wu. Thanks everyone to join this session. Today we have a very good session for organized by the THQA and the JCT and also ASQUA. And we mentioned about the quality care and the patient safety. I'm very thanks for the Dr. Pichumani to mention about the checklist to increase improvement, the quality improvement in obesity, and also Professor Chen mentioned about improve the care in COVID-19 and and AMI care in Taiwan, and we're looking forward to cooperation with WHO and the Indian quality organization in the future. And we also enjoy lots of the webinar organized by WHO and also ASQUA and ASQUA. So today we have a very good chance to communicate with Dr. Pichumani. It's a very honor to have a research section and this symposium. We're looking forward to see you very soon in the future. Thank you so much. Thank you, and good night. Good night. Thanks for everyone, Dr. Wu and Dr. Zhang, and Dr. Yang,
thanks.
Dr. Lin, and also Dr. Go. Thank you. Good night. Bye-bye.
Bye.
Bye.